Dr. Ankur has actually made my job easier. One, he is not physically present. And second, in the case discussion, he has highlighted many of the points which I'm actually going to relate in my presentation. So I'll be talking on the observation component. So as discussed, when we talk of OHT, it is always the OHTA study which we talk of. But if we see in the details, and as Dr. Ankur has already mentioned, 5 variables were specifically highlighted which are predictive of developing glaucoma. And they were age, increased intraocular pressure, a thin corneal thickness less than 555 microns, a vertical CD ratio more than 0.5, and an increased pattern standard deviation. So these risk factors were identified for development of glaucoma. If we categorize all those patients which were enrolled in that study, they could be graded into low risk, middle risk, and highest risk, less than 6%, 6 to 13, and more than 13%. So if you see that difference which we quote was more significant for the highest risk categories and not for the low and middle risk categories. If we see the number needed to treat, whenever we are in a dilemma as to whether to treat a condition or not, we consider NNT, that is the number needed to treat to prevent the disease. So the number needed to treat to prevent just one case of a primary open-angle glaucoma, it is about 16, 17 in the middle and high-risk groups, but it is as high as 98 in the lowest tertial group. So you need to treat 98 OHDs to prevent just one POAG. So why all this debate? Because whenever we are in a zone of uncertainty and the gray areas, we always want to play safe. And the safest for us is to ensure ourselves that we have done something for the patient, and that is by prescribing a drug for the patient, which may actually not be needed. Second thing is, we are always scared of this demon of PAOG. What if the disc develops damage? What if field defects develop? But we now have so many sophisticated tools. We can spend time counseling our patients and spend more chair time with them and explain them the need for frequent monitoring and follow-up. And all the time we are talking of progression, progression, and progression. But what we tend to forget is the effect that treatment will be having on the quality of life of the patient. So that is something which we strongly need to consider. So in an attempt to prevent POAG from developing from OHD, we need to consider the burden of therapy that the patient is going to have. And there needs to be no reference. We all know the burden of therapy, the adverse effects of the drugs, the preservatives, the cost, the inconvenience of therapy, and the compliance issues that are there. And not forgetting the uncertainty of efficacy, when to add, when to substitute, and all those complexities that are there in medical therapy. And now there are risk calculators available free of cost, so you can always feed in your patient's data and see what is the risk of developing glaucoma in that patient, and then you can manage accordingly. So you have to calculate the risk-benefit ratio, what is the risk factor present in that patient, what is the ultimate benefit that is going to be the patient, what is the burden of lifelong treatment, and mainly what is the risk category of that patient. And then we can decide whether we want to treat or to observe. So definitely not all OHDs need treatment, and there is a very strong reason not to treat indiscriminately, and all we can do for these patients is simply observe with a frequent follow-up and monitoring. Thank you.
Thank you so much, Dr. Purvi, and that was a very nice rebuttal also. So I would request my panelists to pay some important points about whether to treat or not to treat. Dr. Subhashini, would you like to say?
Yeah, so well debated, Dr. Purvi. So actually, we need to consider the number needed to treat. And for the high-risk category, it's around, for every patient, at least the number needed to treat, for it would be 7. As compared to the low risk, where you have to treat 98 patients to get to prevent one OHT patient from conversion into the POG. So actually we need not look at the OAT study. I don't know how it applies for the Indians, because the average corneal thickness, they found central corneal thickness as the most important and independent and strong risk factor for predicting progression to POAG from OHT. But if we see the Asia-Pacific guidelines, where the average corneal thickness for Indians is around 502 or 510, around that. So does it, do we come under the high-risk category? So that's the question. So how much to give credence to the OAT study, especially in the Indian scenario, we can't tell. But it's worthwhile treating the high-risk group. Definitely, that is the high-risk group where the cup disc ratio is more than 0.7 and the cornea is really corneal thickness is less than 500. There it's worthwhile treating so that the person does not convert into primary open-angle glaucoma. So this is what, these are important points to be pondered over.
Thank you, Dr. Subhashini. So is there any role of the risk calculator? Any would like to comment? Dr. Preeti, would you like to comment?
The OAT study said that even family history was not important. I mean, we have genes developed for diagnosing which we know that are passed down through generations. So, and the risk calculator also does not take that into account. So I would say instead of giving a numerical value to everything, we just, as OAT study has done, like low risk, middle risk and high risk. And so we have patients, we classify them in which category they fall, one. So I don't use any risk calculator, I just put them into these categories and give family history of glaucoma, weightage. What is the mental mindset of the patient? There are some patients when 20 to 23, they sneeze and they come running to you, my pressure has gone up. So if the patient his quality of life is going to be disturbed that much and he's going to be reassured that I just need one drop and he's fine, I would rather treat. Explaining to him, after explaining that if you're worried, I'm treating you only because you're worried. So I don't use any risk calculator. I have not found it useful in my practice, and I disagree that diabetes has a protective effect. I don't think there is any, evidence in either ways, whether it is protective or it is not protective. So in one sentence, I don't use a risk calculator when I'm advising any glaucoma patients, or OHT patients, sorry.
Thank you, Preeti ma'am. So the bottom line take I would like to take and share it with my audiences, that if your patient is having the high risk factors, please go ahead, discuss the option with your patient, make a patient party to your treatment regime, and then you go ahead with the treatment protocol, whatever you want to start or you want to observe. Let the patient be the deciding factor along with you. So now may I take this opportunity to